Welcome to this explainer. Today, we're going to look at the human body a little differently. We're going to look at it from an engineering perspective. We often think of hernias as just these weird anatomical quirks or maybe simple bulges under the skin. But they're actually fascinating mechanical failures of the body's pressure containment system. Basically, when the internal pressure overpowers the structural integrity of the abdominal wall, things just start to give way. So let's dive right in and explore exactly how and why this happens.
Here is our clinical framework for today. We're going to cover 1. Anatomy and pathophysiology, 2. Clinical features and classifications, 3. Diagnosing and investigating, 4. Principles of surgical management, and finally, 5. The strangulated hernia emergency.
All right, let's kick things off with Section 1, Anatomy and Pathophysiology.
To really grasp what a hernia is, we have to ask a pretty basic question. What exactly is failing here? Well, the word itself actually gives us a massive clue. Hernia comes from a Greek word meaning to bud or protrude, and in Latin, it translates to rupture. In medical terms, it's defined as an abnormal protrusion of an organ or tissue through an opening in the layer that normally confines it. So the absolute crucial takeaway here is that it pushes from the inside out, and because of that outward force, an abdominal hernia takes all the coverings of the abdominal wall right along with it, basically pulling the inner lining, the peritoneum, into this sac-like structure as it escapes its normal boundaries.
But why does that wall fail in the first place? Well, this structural defect can pop up from a few different places. You've got developmental failures, like when the pathway for a descending testicle doesn't close properly in an infant. Then there's weakness just due to aging, pregnancy, or even severe blunt trauma. But here is a truly fascinating medical surprise. Modern surgical science increasingly views hernias as a collagen disease. Yeah, it's often due to an inherited imbalance in the types of collagen found in your connective tissue, which totally explains why factors that mess with collagen maturation, like smoking, massively increase your risk of developing a hernia.
And this image brilliantly illustrates what that structural failure looks like in reality. What you're seeing is the surgical anatomy of an indirect inguinal hernia, which, by the way, is the most common type. Look closely at that peritoneal sac bulging out. Notice how it passes through a very specific defect, the deep inguinal ring, and sits just lateral to those red and blue inferior epigastric vessels. The exact point where the sac squeezes through the abdominal wall is called the neck of the hernia. And as we're going to see in just a minute, the size and rigidity of that specific neck literally dictate everything about how dangerous the hernia might become.
Moving right along to Section 2, Clinical Features and Classifications.
Okay, now that we know how this pressure leak forms, how does it actually show up in a patient? Well, symptoms can range anywhere from a totally painless lump to a full-blown surgical emergency. Let's walk through this high-yield classification table. This is basically the spectrum of hernia severity. We start at the top with a reducible hernia. That's when the contents pop out when the patient stands or coughs, but they return easily to the abdomen. You might even hear a little gurgling sound if it's intestine. But if those contents get trapped and absolutely cannot be returned, it becomes irreducible. From there, the danger scales up fast. If the bowel is trapped and its flow is blocked, we call it obstructed. And down at the bottom is the absolute worst-case scenario, strangulated. This is an irreducible hernia where the arterial blood supply is completely choked off, which inevitably leads to gangrene. And the key driver behind that terrifying progression? It's the danger of the narrow neck. Think about it. If the abdominal wall defect is really small and rigid, it acts exactly like a constriction ring. When tissue gets forced into that hernia sac, this tight little neck stops the venous return, so the tissue swells, the internal pressure inside the sac skyrockets, and the contents become utterly and totally trapped. Basically, a narrow neck is the engine of a hernia emergency.
All right, let's look at Section 3, Diagnosing and Investigating Hernias. Before we can even think about fixing the defect, we have to know exactly what is happening beneath the skin. Now, for the vast majority of hernias, the diagnosis is purely clinical. It's hands-on. It requires a physical exam with the patient both lying down and standing up, and will often use the Valsalva maneuver or have them cough just to make the lump appear. However, there are some specific scenarios where advanced imaging is absolutely non-negotiable. We'll use ultrasound for hidden defects or post-op fluid collections. CT scans are fantastic for mapping out large, complex incisional hernias so surgeons can actually plan out an abdominal wall reconstruction. And MRI? That's our go-to for sportsman's groin, where we really need to distinguish a hidden hernia from, say, a severe orthopedic muscle tear.
And imaging can also throw us some incredible curveballs about what exactly is trapped inside that hernia sac. Check out this cystogram. See that bright white area? That's the urinary bladder filled with contrast. If you look at the arrows, you can clearly see a portion of the bladder being pulled directly down into a left inguinal hernia. This perfectly highlights exactly why surgeons have to be so incredibly careful during a repair. Extraperitoneal organs can literally become part of the hernia itself.
Next up, Section 4, Principles of Surgical Management.
So how do we fix it? Or actually, a better question might be, is watchful waiting ever a safe approach? The short answer is yes, but with some very strict caveats. If an elderly patient has an asymptomatic, direct inguinal hernia, conservative management is usually totally fine. However, and this is a massive however, femoral hernias, which occur a bit lower down in the groin, absolutely must always be repaired surgically. Why? Because the anatomy of the femoral canal creates an incredibly tight, narrow neck, making the risk of strangulation dangerously high. We just can't risk it.
So when surgery is indicated, we follow a few core principles. First, reduce the contents back into the abdomen and manage that peritoneal sac. Next, close the defect if it's possible. And finally, and this is the big one for modern surgery, we reinforce the abdominal wall with the synthetic mesh. The Liechtenstein tension-free mesh repair is the absolute gold standard for inguinal hernias. By using a mesh rather than just yanking and stitching the muscles tightly together, we avoid putting the tissues under tension, which drastically lowers the chance of the hernia ever coming back.
Now, while modern repairs rely heavily on mesh, they're all built upon an anatomical philosophy that was established way over a century ago. Edoardo Bassini, who is widely considered the father of hernia surgery, wrote this back in 1887. This method reconstructs the inguinal canal as it is physiologically, with two rings and with two walls, one posterior and the other anterior. Bassini realized that a true repair meant restoring the actual physiological layers of the abdominal wall. And honestly, that's a principle that still guides surgeons to this day.
And you can literally see that principle in action right here in this open surgical approach. The surgeon has visualized the specific musculofascial layers that failed to contain the intra-abdominal pressure. So whether they're using Bassini's original tissue suture methods or our modern synthetic meshes, the end goal is exactly the same. Bridge the gap, reinforce the posterior wall of the inguinal canal, and restore the mechanical integrity of that pressure system.
Which brings us to our final part, Section 5, the strangulated hernia emergency. We really need to look at the critical tipping point where a simple mechanical bulge turns into a life-threatening ischemic emergency. This is the terrifying ticking clock pathophysiology of a strangulated hernia, and it happens step by step. First, the bowel gets pinched at the narrow neck, which stops venous blood from draining out. Second, because blood can get in but can't get out, the bowel becomes massively congested. It turns this dark purple color, and fluid starts leaking into the sac. Third, the swelling gets so severe that the pressure actually blocks the arterial blood from pumping in. And finally, completely starved of oxygen, the tissue undergoes ischemia, infarction, and ultimately gangrene. If a surgeon doesn't operate immediately, the dead bowel wall will perforate, releasing toxic, infected contents straight into the patient's body.
Which leaves us with this somewhat counterintuitive golden rule of surgery: small hernias can actually be more dangerous than large ones. I know, a massive hernia with a wide neck might look really alarming, but the bowel can usually slide in and out freely. A tiny hernia with a rigid, narrow neck, that is a trap waiting to spring. It demands immense clinical respect. So the next time you think of a hernia, don't just think of a harmless little bulge. Think of the delicate, high-stakes physics of the human pressure system. What structural weaknesses might be hiding under the surface, just waiting for the pressure to rise?